Mrs. Doris Troop is a 47-year-old obese female who presents to the clinic today with chief complaint of neck and upper back pain that radiates all over her body. The pain first began 6 years ago following an MVA, and it's described as a tight and achy pain that fluctuates between a 4 to an 8 out of 10, but is not aggravated by any identifiable factor. She has previously visited multiple providers in the past with similar complaints, and 3 years ago had a negative workup completed for seronegative rheumatoid arthritis. She, as well as her sister and mother, have a history of depression that is currently managed by Zoloft. Along with the pain, she states she has a tingling sensation in both lower extremities, as well as shortness of breath after climbing one flight of stairs, generalized intermittent chest pain, constipation, and urge incontinence. She has tried multiple analgesics to manage her pain and is currently taking methadone with limited success. She states she recently had to discontinue working due to the pain and cannot complete her daily living task, as well as her hobbies such as gardening. She has lost 15 pounds unintentionally in the last 3 years and has felt increasingly fatigued despite taking Ritalin and drinking 5 cups of coffee a day. The patient denies recent trauma, travel, illness, fever, lumps, masses, joint swelling, or any change to medication. Her past medical history is significant for insomnia, as well as hypertension, which is currently controlled by atenolol. She also takes Xanaflex, Ambien, and Miralax. Her past surgical history is significant for a cholecystectomy in 2014, a laparotomy in 2009, a hysterectomy in 2006, arthrodesis of her cervical vertebrae in 2004, a cystocele and a rectocele in 2003. She has also completed recent studies, such as a stress test, and catheterization, an endoscopy, and a colonoscopy, all within the past 5 years with insignificant findings. Her family history is significant for head and neck cancer, to which her father passed away from at age 62. Her vitals today are BP 137/68, pulse 108, respirations 22, temp 98.2, O2 97, height 67 inches, and weight 88.9 kilograms. Upon entering the room, the patient is identified as an obese female that appears uncomfortable, tired, and continuously shifts upon the exam table. She has tenderness upon her temporal region and a clicking sensation when she opens her mouth associated with TMJ. Her mouth lacks lesions, however, of note is a recent extraction of her left second molar, with no complications. Her thyroid was palpated as normal size with no nodules and normal consistency. She has no palpable lymph nodes and no tenderness upon palpation. Though she is slightly tachypnic, her breath sounds were clear bilaterally with symmetrical chest expansion. And though she was slightly tachycardic, she has a normal rhythm, noted with no adventitious sounds. Her abdominal exam is positive for tenderness in all 4 quadrants to light palpation. However, I was unable to palpate her liver and spleen and did not identify any masses. She has full passive and active range of motion in her neck, spine, wrist, shoulders, knees, and ankles, and there is no tenderness to palpation of any of her vertebrae. However, tenderness was noted in her neck and paraspinal muscles, her SI joint, her bilateral wrist, and the medial aspect of her right lower extremity. Her cranial nerves are intact with her reflexes at 2+ in all extremities and her strength 5 out of 5 in all extremities. Her monofilament and clonus tests were negative, and her cerebellar function as well as sensation were fully intact. The current differential that I have composed includes fibromyalgia, chronic fatigue syndrome, uncontrolled depression, irritable bowel syndrome, and polymyositis. The diagnostics completed in office today include a CBC, which was within normal limits, a TSH within normal limits, a fingerstick blood sugar at 84, and an ESR at 11, all within normal limits. I have contacted her rheumatologist and requested her previous rheumatological studies, which are currently pending. From our visit today, it's suspected that the patient is suffering from fibromyalgia. In office, we should reassure her that fibromyalgia is a real disease and that her pain is validated. In order to reduce stress and mood disturbances, I'm going to recommend that the patient tries stress reduction techniques such as medication. To improve her sleep hygiene, I'm going to suggest that the patient develops a regularly scheduled sleep cycle and decreases her caffeine intake. She should also be encouraged to return to work as soon as possible. A strict regimen of exercise should be enacted immediately with this patient, of low-impact aerobic cardiovascular fitness training, such as fast walking, biking, swimming, or water aerobics. The patient should be encouraged to attempt this 30 minutes a day for 3 days a week, and if she's unable to complete this, physical therapy referral may be important. The patient should also be counseled on attending a form of counseling such as cognitive behavioral therapy, or CBT, in conjunction with these exercise and sleep hygiene lifestyle changes. She is currently taking Zoloft, which is a selective serotonin reuptake inhibitor, to manage her depression. However, according to literature, tricyclic antidepressants are most beneficial for fibromyalgia patients. Therefore, today I'm prescribing amitriptyline 10 mg PO once daily to be taken before bed. Evidence also suggests that patients with fibromyalgia should not be on opioids or any other type of analgesics for their pain, as they are ineffective and can be detrimental. This being said, I will contact her provider managing the methadone and her pain management and discuss eventually tapering and eventually stopping all opioids for pain management. The patient should be advised to not take NSAIDs or acetaminophen, as they also have shown to not be effective. Finally, the patient should be scheduled for a follow-up appointment in 4 weeks to review these lifestyle changes, review her pain management, and discuss the pharmacological changes made today and with her other providers.